Well, good evening. I want to welcome everybody to this week's session of Sagis Dermpath Happy Hour. Today, I'm pleased to introduce, although he needs no introduction, Keagan Lee. He will be hosting today's session, and he and I are going to be discussing the importance of communication between dermatologists and the dermatopathology lab. And the means of that communication is the biopsy request slip or the requisition. With that being said, I'll go ahead and turn the floor over to Keagan, who will be discussing requisition matters. Keagan?
All right. Thanks, Tom. Yeah, thanks for asking me to do this. This is a very important topic, especially in this day and age when everybody's getting busier and busier, and biopsies tend to be getting smaller and smaller. It's important to get good communication from dermatologists, and the primary way we get that communication, and usually the only way, is through the pathology requisition. And more I've seen requisitions coming in with minimal information and sometimes incorrect information, which can be misleading. And I'll get a call from the dermatologist saying, "Why did you call it this? It looks like this." And I said, "Well, on the requisition, it said to rule out, mycosis fungoides. So that's what I was trying to rule out." And in reality, I'm not giving them a report that's helpful. And sometimes it can even be dangerous for the patient. So wanted to kind of go through many of the important reasons why communication is so important. And, a lot of these reasons are usually self-evident, but I've seen enough cases and enough examples where people are not, they're not providing good communication, or they're not providing any information to the pathologist, and they're expecting good results. And we have this saying in pathology: garbage in, garbage out. We usually use 4-letter words for that, but it's very true. A lot of times we can just look at something, it's a basal cell carcinoma, give you the answer. But there are other reasons, just other than getting the correct diagnosis for providing accurate information on the requisition. Have you seen some similar things in
your practice? Without a doubt. I mean, okay. And an argument that I sometimes get, and we'll get into this, I'm sure, in a little more detail, is I don't want to provide you too much information because I don't want to bias you. But I really need to underscore the fact that any dermatologist who's worth their weight and has had any type of decent training will never look at the biopsy request slip short of identifying either the accession number or the patient name without making an initial diagnostic impression. So we'll take a look at the slide, identify it as belonging to the particular patient, examine it, come up with a diagnostic impression, and then use the clinical history to fine-tune the diagnosis.
Right.
Most of us realize that there's a tendency in human nature to want to make the shoe fit. And so in order not to bias ourselves, we make a real effort and point not to look at that clinical information first. Wouldn't you say?
Yeah, I agree. I think really a lot of times, especially when the diagnosis is straightforward on the slide, you're only looking back at the clinical to make sure it's consistent with what they were looking for, because if it's not, you could be dealing with a specimen mix-up. So really, I agree. I mean, you look at the slide first to see what you think, then you look over and make sure it jives with what they're thinking. If it doesn't, you go back and look and say, can I make this fit into what they were possibly looking at? So, I mean, with that, I mean, it's just starting from the beginning with a requisition, as you just mentioned, patient name, demographics, these are very important. The wrong date of birth, the wrong first name or last name. A lot of times patients come in as a family unit, they come in husband and wife, or father and son, mother and daughter, and they have the same last name. So making sure that you've got the correct first name and not the parents' name just because that's what's on the insurance. That's important. And we do our checks and balances in the lab to make sure everything lines up as well. But what I've seen more and more is with doctors getting busier and busier, dermatologists getting busier and busier, they're relying more on the medical assistants to fill out the requisitions, to correctly label the specimens, to actually write the clinical information onto the requisition. And you can sometimes tell that that's the case with a lot of misspellings, or it's just not making sense when they write. But that's it. Ultimately, it's the responsibility of the dermatologist to make sure that whatever information is put onto that requisition is accurate. And one of the main reasons for that is I've seen cases that go to unfortunately to court or to liability lawsuits, and the first thing that an attorney will do is come to the lab if it involves a pathology specimen and say, show me the requisition, show me the report, show me everything you have. And we keep all of those things, and we keep the requisitions on file, so they can be used as part of the medical record.
Well, I think that we're required to, by law, keep those requisitions. Yeah, and they're scanned into our system. They do become part of the medical record. And I think what a lot of people don't realize is, even in this day and age with EMRs, I think a lot of people feel like the information from the note auto-populates the requisition slip. Sometimes it does, a lot of times it doesn't. And if you're relying on your MA, as you pointed out, to populate the biopsy request slip, it behooves the clinician to take a look at it, because, as you pointed out, the MA's name is not on the biopsy request slip. Right. Your name is on the biopsy request slip. And I do know, to your point, Keagan, that there was a case that was litigated in the East Coast within the last 5 years. It didn't involve a dermatologist. It involved a hematopathologist, but there was a misdiagnosis of the leukemia. And the misdiagnosis was predicated or due to the fact that the pathologist did not have adequate information to order the correct test, to make the correct diagnosis. And the settlement was against the hematologist for not providing the data, not against the pathologist for failing to order appropriate testing. So the precedent's been set there.
Yeah, definitely. So, going down to on the requisition slip, we make sure all the demographics are lining up and they're correct. The next thing that's really important is making sure that biopsy sites, especially when there's multiple biopsy sites, match up with the specimen bottles. And I've seen plenty of times where, the bottle A, biopsy number 1 is from the face, biopsy 2 is from the leg on the requisition. And when we look at the bottles, they're switched. And usually that's caught in the laboratory, but where it's not caught is when the bottles are mislabeled, and meaning they match up with what the rec is, but in reality, the biopsies were put into the other bottles. And sometimes what we'll do is we'll peel back the labels, and we see that the correct handwritten site was written on there, but then when they went back to slap the labels on, they're incorrect. And I say that because it's important to double check your biopsy sites, and to actually double check that the clinical information is matches those biopsy sites, and that you give as much information as you can for each biopsy site, because those mistakes happen. But really helps us figure out or catch those switches is when we can look at the clinical information and say, okay, it's not matching up with on the slide. And so there may have been a potential switch here. good dermatopathologist will pick up the phone, call, and do a complete investigation to make sure there's not.
Yeah, I would say too, this gets back to a point that I made earlier, that we tend not to look at the history beforehand. One of the first things I think any of us do when we look at a slide, the first assessment you make is anatomic location. And so over the years, most of us get pretty adept at regional anatomy and being able to distinguish different anatomic areas based upon the pathologic findings. So this is another check that we take, but so a lot of times that's when I'll pick it up. I'll look at it and say, wait a minute, this isn't from the foot, this is from the face.
Right. Yeah. The tricky one is when one's from the right side of the face, the other's from the left side of the face, and
yes,
you can't tell.
You just hope it's a benign diagnosis. It's very problematic if they're both the same size. Or alternatively, if two specimens get put in one bottle and the second bottle's empty.
Correct. Yeah. But all those things can really help. So providing as much information as you can, within reason is very important. And then if you ever get something that comes back that doesn't make sense, as you often say, Tom, just pick up the phone and call your pathologist.
Mm-hmm.
And it's always good to double check. And, most pathologists without hesitation pull the slides, take a second look. Let's just make sure everything, is matching up or we didn't miss something here. One of the next things in terms of, providing information, I've seen more and more pathology requisitions come in, and it'll just say neoplasm of uncertain behavior or lesion, and sometimes some of them come in with no, especially the handwritten ones, the ones generated by your EMRs, those usually have some sort of ICD code applied to it, but some of the handwritten ones just come in with absolutely no information. And what I'm seeing, not necessarily in dermatopathology, but I think it's coming soon, in other areas of pathology, the patient's insurance will just reject the claim when you go to submit it, and it's because there is they'll deem that there's no medical necessity for the biopsy because there's no reason provided for the biopsy. Now we all know there is a reason, but they don't need much of an excuse to reject it. So, just for your patient's sake, you want insurance to cover the biopsy as well. Put the information there. That, again, that's on the record. If they ever wanted to go back and reject the claim, they would be able to do that. Of course, we would just get the information, but it's just more work down the line. So that's one other kind of smaller reason, but I am seeing that in more and more pathology specimens being rejected billing-wise because there's no information attached to the requisition. And then we've already kind of talked about the medical legal aspect of it. There's many reasons for that. So if there's a mix-up and we don't have enough information to catch that, obviously that's really bad. But there's also patients can get not only the wrong diagnosis, but they can get a misdiagnosis, meaning we call it something benign. In reality, it's something malignant. And a lot of times where I see that is with inadequate sampling, but it's hard for us to know that it's inadequate sampling of something when we don't really know what the lesion looks like, how big it is it something deep, and we're just getting the surface of it. And a lot of times pathologists will hedge, but no one likes a hedging pathologist. Everyone wants a definitive diagnosis. So the pathologists feel a lot of pressure to try to provide a definitive diagnosis. But for example, adnexal tumors, you sample any part of an adnexal tumor, a malignant adnexal tumor, and it might look benign. So if you provide a little 2 or 3 millimeter shave of something and it's 4 centimeters in size, it's good for your pathologist to know that. And if it comes back benign, I mean, if you're not questioning that, if you don't pick up the phone and call the pathologist and say, this thing's 4 centimeters in size, do you want me to take some other parts of it? That's something where inadequate information can lead to a misdiagnosis. I actually had another case recently where I got a punch biopsy. I just got a little bit of superficial fat in the biopsy, and it came in as rule out lipoma. So I sent it back out, probable surface of lipoma. Now in reality, the lesion was about 10 centimeters in size. It was hemorrhaging. There was necrosis. There was ulceration in the lesion. So I don't know why it came in as rule out lipoma, but that was the information I was given. Luckily, the patient followed up a few weeks later with another dermatologist who called me and said, "Hey, you called this probable surface lipoma," and he gave me all the the information, sent me pictures, and I said, "Yeah, I don't think it's a lipoma. Why don't you go ahead and take a larger biopsy?" And it ended up being a myeloid sarcoma.
Yeah.
So that's another example where inadequate information can lead to a possible misdiagnosis.
Yeah, I think it's, we're kind of an extension of what happens in the clinic. And so one analogy that I kind of like to point out to practicing clinicians, and I did practice clinical derm for a while, when we're kind of hampered that way, the clinical equivalent of that would be to have the MA go into the room, cover the patient entirely up except for the one lesion, one or two lesions, and then gag them so that you coming in as a clinician could just look at the one little spot. You wouldn't have an idea of what the distribution was, what the patient's general health was, and you couldn't ask them any questions about history.
All right.
And obviously, that's not a great way to practice medicine. It doesn't benefit anybody at all. The other thing is, remember that your patients are consumers as well too, and they're getting a bill from us for our services. We want to do the best job that we possibly can. And I know as a consumer of healthcare myself, if I got a result back and then realized later on that the lab didn't have all the information that they needed to make a good or complete diagnosis, I wouldn't be too happy. So,
right. Yeah, and no one wants to get a biopsy back that says it could be these 30 things, and good luck. So it's always helpful if you provide what you're thinking.
And Keagan, in that respect, I think it's always good. I mean, I think it's fine I think it's great to have a scribe to help out with entering clinic notes, et cetera. But I do think as a clinician, if you can just take 2 seconds to look at the rec slip after you do a biopsy and initial it maybe, then that's great. And I know I've noticed too with Emma, and we do have access to those clinic notes sometime, that some of the clinicians, there's a space they can write in there, note to the pathologist. And so you can read that, which really helps us a lot.
Absolutely. Yeah. Especially with rashes,
Mm-hmm.
Sometimes if you'll put your differential, we may not be able to confirm what it is, but we can tell you it's not those other 2 or 3 things that you're thinking of. It's definitely not those, but here's a few other options that it could be. And sometimes you can just by what you're thinking, you don't even have to give a really in-depth description. Just by what you're thinking, I can kind of know what it probably looks like on the patient.
The other thing that I found
are worth 1,000 words too.
The other thing that I found extremely helpful, obviously sometimes, if we can access the clinic note with certain systems, that's great. But if we can't, and it's a fairly complex case, and you've got you have a limited amount of time to describe everything, just the note, pictures available upon request is huge, because then we'll know to call the office or text the clinician and say, okay, I'm ready for the clinicals.
Yeah, and I agree. I think for every case, you don't necessarily need to send photos. Mm-hmm. I do recommend that people take photos of patients if they can, because sometimes, even in the case of a mix-up, you can go back and you could say, okay, that biopsy was definitely a pigmented lesion. That one was not. That one looked more like a keratosis or a squamous cell, and we can go back and kind of say that, that was obviously a switch based on the photos. Because sometimes, like you said, it auto-populates, and the mix-up happened in the EMR.
Mhm.
So it just kind of, the mix-up continued down the line. And so going back to the EMR, you wouldn't be able to tell except for the photos. So I do recommend, if you have time in your system, it's pretty efficient with your system to take photos. They can be very helpful, but especially in the cases that are pretty complex, and you think that those photos might be useful to the pathologist. Photos are a great way to kind of convey what you're seeing. But again, ultimately, you know, if you get back a report that's suboptimal, not really helpful, just pick up the phone. If you're taking a case and you already know it's going to be complex and you don't want to write a 10-page paragraph on the requisition, pick up the phone or shoot a quick text. I'm sending you a really complex case. You don't have to put any patient information in it, but you can just describe what you're seeing. And a lot of times we'll know when we get to that case, oh, yeah, I remember that you texted me about that.
Yeah, I think in this day and age, there's really very little reason to not, with cell phones and texting, to not communicate. So much easier. It's not like, you know, for us, it's not like we're calling and pulling somebody out of a patient room or whatever. So I think there's.
Yeah, I think in some cases where, you know, you may not know the dermatopathologist. You know, if you're sending to a big reference lab that someone different is reading every day, it can be kind of hard to develop that rapport with your dermatopathologist. But you know, you should still make every effort to try to contact them and give them as much information as you can. Don't just accept something if you don't think it makes sense.
I think too, it's probably in the end, this is probably the next thing to discuss. You want to double check the billing information too, to make sure that that's correct on the rec slip. You know, that can be all kinds of problems.
Oh, for the pathology billing?
Yes. Well, and yeah, you just want to make sure everything matches up, you know, there.
Sure. Absolutely. I don't know. Is there anything else that you can think of that we might need to cover on?
No, I just think communication is key. I mean, and I think the advantage of maybe not using a huge lab where you got, you know, different pathologists every day reading things is the communication becomes much easier. And I think as dermatologists, you know, we rely a lot on the interaction with the pathologist. And so, you know, I would very quickly get contact information, cell phones, emails, and don't hesitate to use them. And as you pointed out, if you get a report back that doesn't make sense, just call the pathologist. We can always order additional sections. We can have a dialogue about things. Personally, Keagan, I don't know how about you, how you feel about it. If anybody wants a second opinion, I welcome that. You know, I'm
absolutely
fine. I mean,
especially on difficult cases. You know, I mean, oftentimes I seek that out ahead of time, but if something's not making sense and I look at it and I say, you know, nothing's coming to mind of what else this could be, but let me show this around and just make sure.
Sure.
I mean, at the end of the day, we want to give a report. We want to provide the best health care that we can for the patient. And so that should be the common goal. It shouldn't be anybody's ego. I've seen people say, well, you're a pathologist. You should, you know, they almost think of it like a black box. You should get it right.
Yeah.
Say, yeah, I wish it was that easy, but it's not always. And so getting help, you know, getting another set of eyes to look at it, even showing it around to some non-dermatopathologists, lymphomas and sarcomas. I mean, that without fail, that provides much better care.
I agree. Same team, help us help you. So
that's right.
Exactly. Well, I think that's about all we have. Certainly, if you have any questions at all or anything you'd like to discuss, I would encourage you to email us at education@sagisdx.com. You can also email Dr. Lee or myself. It's our first initial and last name at sagisdx.com. Hope
Yeah,
this,
I'm always interested in hearing people's stories too. So if you have any stories that are related to this, where you saw, providing information or the lack of information, made a positive or negative difference, please let us know. I'm sure this topic will come up again in a future happy hour, whether it's we're looking at unknowns and we're going through things. So having those anecdotal stories really helps to illustrate.
Yeah, for sure. Well, sure do appreciate it, Keagan.
Thank you, Tom.
Thank everybody. Thank you for joining in.
Have a good evening.
You too.